think SARS, it's muted. Uh, Good evening, everyone. A warm welcome to today's VDC educational webinar series. These webinar series we conduct regularly in our VDC. These will be clinico-radiological discussions in which the clinician's perspective is taken into account, and we look into the radiologist perspective. And this will be a webinar in which there will be mutual enhancement of each knowledge, so that it will be for the betterment of the patient management and diagnosis. So we come up with these topics based on the recent advances and new technologies which are coming up in the field of medicine. So today we have selected a very interesting topic. It is nephron sparing interventions in renal tumors, the radiologist's role in this subject. So coming to our chief guest, we have Dr. Vamsi Krishna. He is the HOD of Department of Urology in Care Hospitals, Hyderabad. Hello, sir. I welcome you. In spite of your busy schedule, you have graced this webinar. Thank you so much. And he has done MBBS from Gandhi Medical College and MS General Surgery from PGI Chandigarh and M.Ch from BYL Nair Hospital and Topiwala National Medical College, Mumbai. He has done certificate course in robotic surgery by Intuitive Surgicals in 2016. He has worked in various multi-specialty hospitals in Hyderabad and is currently working in Care Hospital from December 2017. His areas of interest are endourology, lasers, laparoscopy, and robotic surgery. He is keen into research and publications and has attended multiple state, national, and international conferences and has numerous publications. He has attended many live workshops as an operating faculty. He is a member of various urology societies. He has performed more than 1500 RIRS procedures, performed advanced laparoscopic surgeries like radical prostatectomy, pediatric laparoscopic pyeloplasty, and he has performed robotic assisted nephroureterectomy, adrenalectomy, and non-refluxing ureterocystostomy. He was adjudged Inspiring Urologist of India 2019 for the state of Telangana by Times of India and awarded Service Excellence in Urology in 2021 for state of Telangana by Economic Times. I welcome you, sir. And the expert speaker for today's topic is Dr. G. Prasad. He is Senior Consultant Radiologist in Vijaya Diagnostic Center, Dilshinagar branch. He has done his MBBS from Armed Forces Medical College, Pune, and DMRD from Topiwala National Medical College, Mumbai, and DNB from Pushpagiri Institute of Medical Sciences, Tiruvalla, Kerala. He has worked previously as clinical assistant surgeon in Amrita Institute of Medical Sciences, Kochi, and has post DNB experience of about 13 years and is working in VDC since 2013. I welcome you, sir. So, coming to today's topic, previously these renal tumors are usually treated by radical nephrectomy, but nowadays the trend has changed, and most of the surgeons and the patients are preferring partial nephrectomy because the radical nephrectomy has its own disadvantages, like the patient will be left with only single kidney, which might get affected in later stage, and even many patients might have a single kidney by birth and in post-renal transplants also. And due to recent advances, even robotic surgery is helping us in treating even complex renal tumors by partial nephrectomy. So this topic is very important, and it will enhance the knowledge of the radiologist and to give a perspective what a urologist wants in his report. So, and different types of scores and describing the complexity of the renal tumors is very important. So, I would request Dr. Vamsi Krishna sir to give his clinical perspective of the renal tumors. Sir, over to you.
Sure. Good afternoon, everybody. First of all, I thank you, team radiologists at Vijaya Diagnostic Center, LT Kishore sir, Dr. G. Prasad, Dr. Dileep, for inviting me to chair this session. So this is a very interesting topic. This is one of the issue where surgeons, radiologists sit together for every case almost. We see, discuss with the radiologist, and then find out more intricate details which are not just mentioned either in the report or the films provided with the patient. So, as you mentioned, nowadays more and more patients are coming with incidentally found tumors on either a routine health checkup or evaluation for other diseases in the kidneys. And most of the tumors can be dealt by nephron sparing surgical techniques, partial nephrectomy, enucleation, enucleoresection. So these are different nephron sparing surgeries. Non-surgical techniques are also there: cryotherapy, ablative treatments, radiofrequency ablation. So, but most of patients usually we go for a nephron sparing surgery because of availability of tissue for biopsy and diagnosis. So, what exactly we look when we ask for a CT in these patients? Score is whatever the score you mentioned. Yeah, we have many scoring systems here. We have Padua score, we have renal score. So we are looking for the relation of the tumor with the arterial vascular anatomy of this kidney. So what is the vessel which I can safely clip without compromising the normal parenchyma? So selective clamping, whether it is possible. Should I dissect through the hilum instead of directly going on the tumor to first select the vessel which has to be clamped? This is called selective hilar clamping. And also the relation of this tumor to the pelvic calcium system. So if I am opening the tumor, which part of the pelvic calcium system is going to be open, and should I put a ureteric catheter before I start dissecting the tumor? So should I put ureteric catheter, inject some dye to see if the pelvic calcium? So the relation with the pelvic calcium system, the arterial, and of course venous anatomy. So if we can get a very three-dimensional view of these relationships with in respect to tumor. So even a hilar complex tumor, if we have the right information, we can still save the kidney for them. So with this approach, over to Dr. Prasad, if you can enlighten us. I can add some more. I have few short video clippings of the next what is going to come in the future. If we are not covering that, maybe I'll take 1 or 2 minutes. So with this perspective, I think we'll listen to what Dr. Prasad says, and then I can add something if you want.
Over to you, Prasad.
Good evening, sir. First of all, thank you, Mr. Dr. Dileep, for the introduction. Good evening, respected Chief Guest, Dr. P. Vamsi, Krishna, sir. I thank you again, and I welcome again for joining the webinar, sir. And first of all, I would like to thank Vijaya Diagnostic for giving me this opportunity to present the talk. Coming to the topic, my screen is visible?
Yeah.
Yes, sir.
Yeah, okay. Okay, right. Thank you. Most of the cases, relevant cases in the presentation I have taken are from a routine radiology practice in Vijaya Diagnostic Center. Few of the diagrams and few of the images I have taken from the standard radiological education websites and few standard journals, without which the presentation may not be complete. So beginning with the topic. What I have divided the topic into initial the introduction, why the topic is important. Like sir has already told that many of the cases are actually incidental findings. So this makes more important to discuss the present topic. And I have discussed few like differentials and the classification of the renal masses, relevant cross-section anatomy, just a couple of slides. Then imaging protocols, what do we follow? And then understanding of the renal cell carcinoma staging. When we say a tumor is renal confined and the tumor is going beyond the kidney margins. And like sir said, we are discussing few commonly used nephrometry scorings, and then very few again post-operative findings. So beginning with the topic, renal cell carcinoma accounts for about 3.5% of all malignancies in adults, and there is a rise in incidence of renal masses due to easy availability and increasing use of the imaging techniques like ultrasound and MDCT. More than 50% of the renal cell carcinomas are detected incidentally. More and more of the renal tumors are discovered in their early stages, with the greatest increase in the renal tumor size between 2 to 4 centimeters, which favors a more conservative surgical approach like nephron sparing surgeries, and like sir told, even non-surgical techniques like percutaneous image-guided ablations. For smaller renal masses, the outcomes have been shown to be equivalent for partial and radical nephrectomy. A total nephrectomy has significant impact on the renal function, and the incidence of chronic kidney disease is high, which further leads to cardiovascular diseases and is an important contributor to the overall mortality. Nephron sparing surgery prevents future reduction of this renal impairment compared with the matched patients undergoing radical or total nephrectomy. When we go to the differentials of renal masses, there is a long list, right, from the renal cell carcinoma, which is the most common one. Others like oncocytoma, angiomas, which may vary from lipid-rich to lipid-poor or lipid-invisible varieties, metanephric adenoma, urothelial carcinoma, and so on. But a better way to maybe look at the differential will be like describing them whether they're ball type lesions or bean type lesions. That means whether they're contour deforming lesions in the kidney, which is a ball type lesion, where we can see exophatic bulge in the contour of the kidney, or it is a bean type lesion, which is more of an infiltrating kind of lesion involving the cortex and the medulla. It has got both radiological as well as clinical implication. In radiological implication, these exophatic ball type lesions are relatively easier assessed, picked up on even on non-contrast CTs, where we can pick up them incidentally also. Whereas in bean type lesions, unless clinically or radiologically suspected, these lesions can be missed. So the common differentials in ball type lesions include renal cell carcinoma, angiomyolipoma, oncocytoma, or sometimes metastasis lymphomas can also be present in this pattern. Bean type lesions, we have lesions like transitional carcinoma. Again, renal cell carcinoma rarely, in few 3 to 5% cases, can present in this pattern also. Other differentials include lymphoma, metastasis, and also non-neoplastic lesions like infection and infarction. Cystic renal masses, which are defined as renal mass with greater than 75% non-allogeneic components and are less likely to be malignant than are solid renal masses. And malignant cystic renal masses are less aggressive usually than malignant solid renal masses. Cystic renal masses evaluated at CT or MR without and with IV contrast and are further characterized by the Bosniak classification system version 2019 and are managed accordingly. Just for information of our viewers, this Bosniak classification we have discussed in detail in our previous webinar sessions also, and is again available online. So I will not be going in details in the Bosniak system. So classification of the renal masses according to their nature, which is usually done either in like histopathologically, which is available either in post-surgical specimens, or like sir said, when patients are not suitable for surgery, there we can have a go for a biopsy and assess the nature of the lesion. Of these small renal masses, almost 20% are benign, and this incidence is higher in young to middle-aged women. 20 to 25% are potentially aggressive, and almost 60% are indolent. And based on these characters, further management can be planned. Though RCC is the most common differential, usually no clinical or radiological feature can predict the malignancy in RCC. Very quickly, we'll review the relevant radiological anatomy, where we can see kidney is located in the perinephric space, which is an inverted cone space located in the retroperitoneum on either side, containing the kidney, ureter, renal vessels, lymphatics, and which is surrounded by the perinephric fat. Perinephric fat. And this perinephric space also includes the adrenal gland, which is located above the kidney. We have renal fascia, anterior fascia and posterior fascia, and anterior and posterior aspects of the kidney, which separate the perinephric space from the anterior pararenal space and the posterior pararenal space. Anterior renal fascia, also known as Giroda's fascia, and the posterior one is the fascia of Zuckerkandl. And this fascia, on medially, they both join together, and medially they reach on the right side, they join with the connective tissue around the ureter, whereas on the left side, medially, they join with the connective tissue around the aorta and the IVC. And laterally, these two fascias join together to form the lateroconal fascia. Superior extent of this fascia on either side reach up to the level of diaphragm, and inferiorly, both of these fascias join together and unite further joining onto the iliac fascia. So how does this fascia looks on cross-section imaging? Normally, in a normal scan, we may not be able to see this fascia unless until they are thickened. So thickening of this anterior or posterior renal fascia, they may be seen in various conditions like infection, inflammation, or infiltration. This is just to show how this fascia looks. On the left side, on the top and lower images, we have a non-contrast CT where we can see a calculus in the left pelvic junction causing renal obstruction associated with perinephric fat stranding edema and the thickening of the anterior and posterior pararenal fascia. Again, lower image showing the same thickening of the anterior and posterior pararenal fascias. On the right side, the top image is axial T1 image of an MR, and the lower one is a coronal T2 fat sat sequence. again showing grossly increased signal in the left renal parenchyma due to pyelonephritis. And again, this is to show the thickened anterior and posterior renal fascia around the kidney, and which is extending above to reaching up to the level of left adrenals also. So coming to the protocols, how do we scan these patients? In patients with normal renal function, the most appropriate imaging modality to fully characterize an indeterminate renal mass is a renal CT or an MRI. The Society of Abdominal Radiology (RCC) disease focused panel recommends following phases, which we cover in CT: pre-contrast scan, that is non-contrast CT; nephrographic phase, which is post-contrast injection after about 100 to 120 seconds; optional imaging recommended in the corticomedullary phase, which is around 40 to 70 seconds after the contrast injection; and the XVT phase, which is taken at 5 to 10 minutes delay after the injection, contrast injection, is recommended if the imaging is performed for pre-procedural planning. However, at our institute, we routinely perform all these phases, and we find especially corticomedullary phase, which is beneficial for assessing the early enhancement pattern of the tumor. So how does different phases look like when we do a CT? On the left side top, we have non-contrast CT. Again, we cannot differentiate whether it is cortex or medulla. It's homogeneous attenuation of the kidney. On the lower down, we have a corticomedullary phase, where, as the name suggests, we are seeing the briskly homogeneously enhancing cortex and the less enhancing medulla in the corticomedullary phase. In the nephrographic phase, both the cortex as well as medulla enhance homogeneously, and this is the phase where these renal tumors stand out separately and are better appreciated. Lower down, again, we can see the excretory phase, where the contrast is excreted into the collecting system, where we can assess the closeness of the tumor with the collecting system and the chalasis. Coming to the MR protocols, again in MR, we have axial or coronal T2 weighted sequences and the axial T1 weighted sequences, which including in-phase and out-phase sequences, which is a chemical shift imaging sequence to assess fat content within the lesion. And we have pre and post contrast T1 weighted sequences in multiple phases, like similarly what we have acquired in CT, and axial diffusion in ADC images for further characterization of the tumors. Just to see how these images look like, on the left side top, we have coronal T2 weighted images showing renal parenchyma, cortex as well as medulla. We can make some differentiation between the parenchyma and cortex and the medulla even in non-contrast CTs, coronal T2, non-contrast MRI, coronal T2 image. On the right side, we have coronal T2 fat site sequence, where some cysts and other pathologies they are better appreciated in this sequence. On the left side below, we have T1 in-phase and out-phase sequences, where the T1 hyperintense structure shows signal loss in the out-phase sequence, suggesting a fat-containing lesion, where in this case it is an angiomyolipoma. Again, on the left side top, again we have diffusion-weighted sequence, where the images is not of high resolution, but we are more interested in looking at the nature of the lesion, whether it is hyperintense on diffusion or low signal in diffusion-weighted. Correspondingly, lower down, we have a ADC map, where we see whether the lesion is restricting in ADC or not. This diffusion in ADC are to assess the water content in the lesion and water restricted pattern. So wherever hypercellular lesions or mass lesions, they appear bright on diffusion and correspondingly low signal in ADC. On the right side, above and below, again we have pre and post contrast T1 weighted sequences to assess the enhancement pattern of the tumors. So this is the basic protocol we follow. And enhancement at CT is classically determined by an increase of at least 20 Hounsfield units or more between non-contrast and contrast enhanced phases. An increase of HU between 10 to 19 is considered indeterminate, or sometimes known as pseudo-enhancement, which is due to beam hardening artifacts. And MRI enhancement is defined as a greater than 15% change in the signal intensity between pre and post contrast T1 weighted images. Or also it can also be set positive when we have subjective definite enhancement on subtraction images. So we will just go through now the staging of the renal cell carcinoma, T1 to T4. T1 and T2 are the renal confined tumors, and the tumor size ranges from 4 to 10, less than 4 to less than 10 centimeter size. T3 is the tumor where it is going into perinephric fascia, perinephric planes. However, does not go beyond the gyrotas fascia or the posterior renal fascia. And T4 again is local tumor infiltration. So we'll see the stages a little more detail. T1 again, T1A, the tumor is less than 4 centimeter size. T1B is 4 to 7 centimeter size, and we can see the tumor is confined to the kidney and does not go into the perinephric space. You can see on heterogeneous transition within the kidney is more no definite expression in the pregnancy stage. Again, T2, similar appearing lesion, size is bigger. It can be less than 7 in 2A or more than 7 up to 10 centimeter, more than 10 centimeter in stage 2, T2 stage. T3A, where T3A we have two patterns where the tumor is going either externally into the pelvic space or internally it is involving one of the major renal veins. Just the corresponding image on the right side, we have axial contrast CT image where we see large size tumor is going into the pelvic space with lot of renal fat running and hypervascularity. T3B and T3C, where we have infiltration of the IBC. T3B is infiltration of the infradiaphragmatic IBC, and T3C is the involvement of the supradiaphragmatic IBC. On the right, we have coronal enhanced CT image showing infiltration of the tumor into the right ventricle as well as into the IBC, extending up to the intrahepatic segment of the IBC. T4 stage, where we have local infiltration of the tumor beyond the confines of the renal fascia. Like here, we are seeing infiltration of the liver on the right side by the enhanced mass lesion. And again, involvement of the adrenal gland is also included in stage T4 itself. So here, the tumor is not confined to the kidney. So once we have seen how the lesion is, whether it's located inside or outside the renal parenchyma, then we have to, whenever they are confined to the tumor, tumor is confined to the kidney, we have to score according to the renal nephrometry scoring. There are few nephrometry scoring available. We'll see few of them. The most common one used is the renal system, which was initially described in 2009 by Kutikov and Uzo, and is the first objective system that quantifies the complexity of the renal tumor. The nephrometry score, which is determined from cross-section imaging, stratifies renal masses into low, intermediate, and high complexity. Contrast-enhanced imaging is recommended, and if contrast-enhanced imaging is contraindicated, unenhanced MR can also be used to assign the nephrometry score. So, renal nephrometry scoring system is an objective method to help in the decision of surgical approach to resect organ-confined renal tumors. Before development of this score, there were no other standard methods to assess the complexity of the renal tumors. Nephrometry systems achieve two primary goals. First is the methodological analysis of the tumor location, and second, standardization of the reporting of the tumor data. Other goals of this nephrometry scoring are to predict success of the partial nephrectomy, risk of post-operative complications, functional and oncologic outcomes. Renal nephrometry scoring systems have been shown to provide important pre-operative and peri-operative information used to predict long-term outcomes and is increasingly been incorporated into clinical trials. So, renal nephrometry score is based on 5 most reproducible features that characterize the anatomy of the solid renal mass. So, these features are, as the name suggests, they stand for the abbreviation renal. R suggests the radius. However, this is a radius, but we include the maximum tumor size. E is the exophytic or endophytic properties of the tumor. N is the nearness to the collecting system. A is anterior posterior location, and L is relation to the polar line. Suffix X is assigned whenever we cannot assign it as anterior or posterior in the kidney, and additional suffix H is assigned when it is abutting the renal vessels, main renal vessels like hilar renal artery and vein. We'll see the individual descriptors. Letter R stands for the R descriptor, which is the radius. Again, as I said, we consider the maximum size of tumor for this parameter, and when it is less than 4 centimeter, it is given a score of 1. When it is 4 to 7 centimeters, given a score of 2, and those more than 7 centimeter given a score of 3. Tumor size is the important prognostic indicator for oncologic and surgical outcome, risk factor for urinary fistula formation and post-op renal failure after partial nephrectomy, and it is the single most common variable and important implication for overall prognosis. Letter E denotes the exophytic or endophytic nature of the lesion. When it is more than 50% exophytic, it is given a score of 1. Less than 50% exophytic, given a score of 2, and completely endophytic, given a score of 3. This is based on the fact that lesions that are predominantly endophytic pose a greater surgical challenge than those are exophytic. N denotes the nearness to the hilum, and this is again described more than 7 millimeters away is given a score of 1. 4 to 7 millimeters of distance of tumor from the collecting system given a score of 2, and less than 4 mm is given a score of 3. That means the nearer the tumor to the collecting system, higher the risk. Descriptor A, which is to decide whether the lesion is located on the anterior or posterior aspect of the kidney. This is determined on the axial image, and A for anterior and B for posterior. Sometimes when the tumor may not be assigned anterior or posterior, it is given a designation of X. Coming to the L, which is described in relation to polar lines. These polar lines are located in the upper and lower part of the kidneys. When we see there is a medial located at that line where there is a medial interruption in the renal parenchyma due to the perirenal fat and the renal vascular pedicles. So wherever this interruption occurs, there we have the superior polar line, and in the lower margin where this interruption occurs, we have the inferior polar line. So these tumors are located just according to the relation to this polar line. A score of 1 is given when the tumor is entirely above or below the polar line. A score of 2 is given when they are crossing the polar line, and score of 3 is given when they are crossing the polar line from more than 50% of the tumor, or they are reaching up to the central midline axis of the tumor, or they're lying completely within the interpolar locations. All these three patterns will be given a score of 3. So depending on this scoring, all these parameters are given a score, and final score is obtained. And there, and according to the scoring system, low complexity tumor have a score ranging from 4 to 6, moderate complexity have a score of 7 to 9, and high complex tumors have a score of 10 to 12. Renal score, some studies have shown that renal score sum was lower, between 4 to 6 and 7 to 9, in tumors treated by partial nephrectomy by minimal invasive approach. Score of 10 to 12 were more likely to undergo laparoscopic radical nephrectomy or an open partial nephrectomy. And tumor diameter of more than 3 cm and nephrometry score of more than or equal to 8 were significantly associated with malignancy and unfavorable pathology. Higher nephrometry score were associated with increased risk of conversion to radical nephrectomy and warm ischemia time. And no significant differences were observed in operating time, blood loss, length of hospital stay, complications, positive surgical margins. A word of caution while using this nephrometry score, like we can see on the left image, the axis of the kidney is not same as the axis of the spine in the coronal image, and on the sagittal images also it is lying oblique, so that the axis of the kidney is different from the axis of the abdomen. So for example, in the left top image where we see there is a mass lesion, enhancing mass lesion in the kidney, if we see only the axial image, we may presume that probably it is lying in the interpolar region or is in somewhere in the midpole region of the kidney. However, when we have a closer look in the sagittal image, this lesion is lying totally in the lower pole of the kidney and below the inferior polar line. So we should always assess the lesions according to the long axis of the kidney rather than long axis of the spine or rest of the body. Just an example to show how the scoring system is done. On the left, again, we have enhancing mass in the posterior margin of the kidney, which is more than 50% endophytic, and hence which is given a score of 2 for the E descriptor. Rest are 1 scores only, and the total score coming as 5. And since it is located in the posterior parenchyma, the total score is 5P. Similarly, on the left side, we have moderate size enhancing lesion in the completely endophytic lesion, and it's quite moderate in size, and it is lying reaching up to the interpolar region. So finally getting a score of 11. And X, since it is neither in the anterior nor posterior, descriptor X is added at the final score. Again, another tumor located in the lower pole of the kidney, where it is a smaller size. However, since it is more than 50% endophytic and its closeness to the system, pelvic system is between around 4.9 millimeters. So overall, the score comes to be 6A, and since it is lying to the anterior parenchyma, A descriptor is added. Coming to the Padwa score, which is pre-operative aspects and dimensions used for anatomical classification or the Padwa system, which was reported in 2009 by Fikara et al. This system is again very similar to renal methodology, which we have already seen, with few salient differences. Again, radius parameters remain same. Endophytic, esophageal components again remain nearly same, like in the renal scoring system. Location, sinus line, which are located above or below or crossing of the sinus line of less than 50%. In crossing the sinus line more than 50% or falling entirely between the sinus line is given a score of 2. Then renal rim is very important, and instead of going anterior to posterior like in renal system, here we are seeing the renal rim as lateral or medial margins. Renal sinus is included where we see the absent relationship or a renal sinus location. Collecting system, again we should see the location whether there is an absent relationship or the collection system is dislocated or infiltrated. Finally, these parameters are again scored, and we assess the risk of the tumors according to the scoring system. Low risk is between 6 to 7, intermediate between 7 to 9, and a high risk is bit more than 10 of score. Is it just a salient difference between the renal and Padua? In the renal scoring system, we have seen the sinus polar lines where there is interruption in the medial margin of the kidney by the renal vasculature. Whereas in Padua score, we are seeing sinus lines. Sinus lines is actually wherever the in the axial cut, wherever the renal parenchyma is interrupted by the renal sinus fat, that section is taken as the upper sinus line. And similarly in the lower pole also, wherever the sinus line ends, there we take it as the lower sinus line and describe the tumor whether in relation to these sinus lines lying below, crossing, or in between these sinus lines. And inclusion of renal sinus is a separate parameter in the Padua system, which is not a parameter in the renal system. In a retrospective study of Padua score in 74% patients of open partial nephrectomy by Groga et al., Padua score predicts the risk of surgical and medical perioperative complications in patients undergoing open nephron sparing surgery. Padua score's cutoff values of 8 was the threshold to predict significant increase in the complication rate. Limitations in both renal as well as Padua scores, cutoff values in some parameters in this system like tumor size or nearness to the renal sinus were selected based on simplicity rather than any clinical relevance in predicting any surgical outcome. Only 4 parameters in these systems, namely radius, nearness to the collecting system, location related to the lateral rim, and centrality, were found to be clinically significant variables on multivariable analysis. Just we'll enumerate 2 more scoring systems which are not usually very commonly used, but as a radiologist we should be aware of. Another is the C index or the centrality index, which was proposed by Simmons et al. In 2010, is based on the pattern of tumor growth into the renal parenchyma and uses tumor centrality as the main parameter to be evaluated, where the kidney is supposedly drawn as an ellipse and the tumor shown as a circle, and we find out the tangential distance between the center of the kidney and the center of the lesion. This uses a Pythagoras theorem for finding out the exact distance. So as the C index increases, tumor periphery becomes more distant from the center of the kidney. So higher the C index, lower the central extension of the tumor into the kidney, and nephron sparing surgery is more feasible with lesser complication rate. Ischemia and operating time tended to be longer, and estimated blood loss was higher in tumors with a C index less than 2. The limitation of this system is that complexity of the calculation, and it gives lesser information about the tumor characteristics. Another scoring system, which is zonal nephro score. Again, just to be aware of this, that such a scoring system exists. We are usually not using them routinely in our practice. There are few 4 parameters. One is the nearness. The kidney is divided into zones. First zone is the cortex, where the mass touches the cortex. Second zone is the medulla, where mass touches the medullary cavity. And zone 3 is where the mass touches the collecting system. Then physical zones. When the tumor is lying in the zone 1, completely below the lower pole collecting system. Zone 2, where the tumor lies in the lateral part of the kidney, interpolar region, but not touching the collecting system. And when kidney is located in the upper pole or is touching the collecting system, it is lying in the zone number 3. And based on the size, it is divided into less than 2.5 centimeter size, 2.5 to 4 centimeter size, and more than 4 centimeter size. And organization stands for, again, endophytic or exophytic nature of the lesion, where the lesion is more than 50% exophytic in zone 1, 50 to 75% endophytic zone 2, and more than 75% zone 3. Again, all the scores are added, and we get a risk tumor assess risk about the score. Low risk is between 4 to 6, intermediate risk between 7 to 9, and high risk between 10 to 12 points. Though nephro score better predicted complication rates, renal scoring system better predicted POM ischemia time. In a study by PGIMER et al., 4 established scoring systems, Padua, renal, nephro, and C index were compared. POM ischemia time and clamp time, all scores predict significantly. Collecting system injury, all predict, but nephro better. Severe complications, all scores predicted except C index. Estimated blood loss and transfusion rate, no correlation. Operative time, C index and nephro better. C index and renal better. In a retrospective study of 188 patients by Borgman et al., laparoscopic partial nephrectomy assessed for margin, ischemia, and complications. Renal score outperformed Padua and C index in the assessment of these complications. Padwa score was not predictive of margin ischemia or other complications. Again, coming to post-operative evaluation, in cases of partial nephrectomy, we can have early complications, or they can be late complications or later post-operative related changes. Early complications include hemorrhage at the post-operative site, urine leak. They can be vascular related or infections. Late complications or findings can be post-operative granulomas, fat at the excision site, linear or stellate parenchymal scar, retroperitoneal space-like lesion, which can be standing or a mass or pseudomass-like lesions, ischemia, and recurrence. We'll see a few of them. This was a follow-up case of partial nephrectomy where we can see in the non-contrast scan showing the hypertension surgical clips in the posterior margin of the parenchyma and the contour defect in the interpolar region of the kidney with normal enhancement in the rest of the kidney. There is no evidence of a residual or a recurrent lesion. Post-activity phase shows normal contrast expression in the collecting system with no contrast. Parenchymal defect expected post-operative finding in partial nephrectomy. Other findings can be sometimes seen post-operative melanoma, where we can see very minimally enhancing presence region in the kidney, normal contrast expression in the this is post-operative melanoma. You can have some stellate or irregular shape non-enhancing areas at the site with the parenchymal scars. Perinephric strands, which are again post-operative related changes. We can see in the perinephric space, fat strand is seen. And pseudomass-like lesions can be seen where we have mass-like density with no significant enhancement and no significant mass effects around the structures, which is again post-operative related finding of itself. Post-operative related retroperitoneal space changes should be differentiated from other complications such as urinoma, hematoma, or abscess, which require immediate management and which presents with symptoms like inflammation, infection, or bleeding, and they show mass effect and relatively larger size. On the left, again, we can see moderate size hyperdense lesion on a non-contrast CT at the site of post-surgical site, suggesting an hematoma. Again, lower image, different case, showing collection in the right anterior pararenal space, extending up to the inner aspect of the abdominal wall, which shows peripheral enhancement. It shows suggesting a collection like either an infected urinoma or a collection like an abscess. On the left, at the near the post-surgical site, we can see wedge-shaped hypoenhancing area in the upper pole of the left kidney, suggesting ischemia in the adjacent parenchyma. Again, this is follow-up case where at the post-operative site we can see small nodular enhancing focus in central part of the post-surgical site, which on further follow-up showed an increase in the size, suggesting a recurrence of the tumor at the surgical site. So to conclude, multiphasic contrast enhanced images is the investigation of choice for indeterminate renal masses. Enhancement in small renal masses should be looked carefully, and recommendation is to measure and report the Hounsfield units rather than describing them as nil, none, or minimal. Better to use Hounsfield units while describing reports. The renal and nephro scores system require only 4 parameters and are hence more favorable for use, with renal system being the most commonly used one. And large number of scoring systems are available, which leaves us with area of improvement and more external validation. Thank you very much.
Thank you, Prasad sir, for an exhaustive and excellent talk. And this is very informative. Even I am hearing these scores for the first time. After seeing this webinar, my knowledge has increased more on these renal tumors, because I have not seen many reports with renal scores even in Vijaya Diagnostics. So I think radiologists are less well versed with these scoring systems. Of course, in the report we give it as invasion of the perinephric fat and calluses and tumor size, but we don't objectively score them.
Yeah.
So I think those are very useful points even for the urologists to reset those, because in nowadays robotic surgery they are doing just enucleation just with minimal tumor margins, free margins. So if it is near to the pelvic calc system, the risk of urinoma formation, post-op urine leaks, and all that are very common. So giving those informations are very important for the surgeons. and the renal vascular anatomy, as sir has said, because to clamp each vessel and not we can resect the tumor freely. So nice talk. And over to you, Vamsi Krishna sir, if you have any doubts or any comments regarding any questions.
It's a very excellent presentation with focus on many images with different stages of the tumor, scoring systems, follow-up. So very nice presented topic, sir, Dr. Prasad.
Thank you, sir.
So, yeah. So there are 2-3 issues I want to add. One thing is many times when there is a tumor abutting the renal sinus, so we see that it is mostly it's a small tumor and we go for a partial nephrectomy, and final report say renal sinus fat invasion is T3 disease. So T3 is not amenable for partial nephrectomy. So whenever any radiologist gets a doubt that the renal sinus is just being abutted, so better they focus on that area and they can comment or magnify the image and say it is abutting, and then specifically comment on that area, because some urologists may miss this finding, and if they go for a partial nephrectomy and post-operative biopsy which comes 1 week after the surgery, if it shows T3, then one has to go, and then maybe it's a difficult decision whether to go or follow the patient. So it's one important consideration to the radiologist to see sinus fat is more important. It will upstage the disease by twofold. Instead of a T1 small 2.5 centimeter tumor infiltrating the sinus fat and not infiltrating, will be a T1A to T3 directly. So that is one thing. Second thing is, as Dr. Dileep mentioned, nowadays we are doing enucleations also. It is now can be called standard of care for difficult location tumors like hilar tumors. What is enucleation is for margins. We need to be tumor free margin, that's all. There is no earlier like 1 centimeter margin, 5 mm margin. So in nephron sparing surgery, margin negativity is enough as a standard. So if there is a slow growing tumor, there will be a normal pseudo capsule which is found by the normal parenchyma, which is a compressed renal parenchyma. So if this pseudo capsule is clearly made and there is a clear-cut demarcation is made on a CT scan, so the surgeon can plan for an enucleation. If there is an infiltrating tumor without a clear demarcation between the renal normal parenchyma and tumor, then enucleation is not recommended. It is not possible. So in that situation, one has to go for a radical nephrectomy or feasibility whether we can do a partial nephrectomy. So describing the renal margin of the tumor, whether it is an infiltrative type or any finger-like projections are entering the parenchyma, or well encapsulated, or at least there is a tumor pseudocapsule is found, will help anyways the surgeon will see the films and discuss with the radiologist, but it will definitely, if you put it in paper in the report, it will be adding to this thing. Third thing, if certain images where, as I mentioned, if instead of just giving the actual images or coronal images, if some kind of 3D reconstruction like you do for like volume rendering or MIP images, where only the tumor and with the outline of kidney with the vascular anatomy in different views. So that will definitely help plan us for the kind of where we can start the incision on the kidney surface. As I mentioned, which vessels I can dissect further into the kidney tissue and clamp it. All those information we can get if the images are provided. Sometimes the study is being done at a different center and the patient won't get the CD of that images. So only the films are provided. If these images are also given with the film, it will be very useful for the surgeon to understand and have a cognitive memory of this tumor when he is actually operating. And if you can permit me, I can show what is the next in thing in radiology, what people are discussing now. Probably right now it is not available in India, but what we have seen in our conferences, what they are coming up with. If you can give 2 to 5 minutes time, I can show a bit of video if
Sure.
time is there. Yeah.
Yes, sir.
Deepak?
Sure.
Um, which one? So there is a company called Inner Sight. I don't know whether you have been aware of. So this company takes the images. Uh, screen sharing. So is it possible to share my screen?
I think
Yes.
it should be possible, sir. Lower down, I think some arrow kind of
Yeah,
thing is.
present I made. Then choose what to share with StreamYard. Then entire screen. Then I am not having the clickability of share button.
I
So
think I have to stop maybe. 1 minute, sir. I'll just find
yeah,
out.
maybe you have to stop your screen sharing. Then I can.
Uh, okay, I have stopped, sir.
Yes, sir. I'll try again.
Yes.
Are you getting my screen, sir?
Uh,
Are you
No,
able
sir.
to
I
see?
can't.
I'm getting the message. StreamYard is sharing your screen.
yeah. The whole screen is getting shared. Yeah.
Yeah,
I'm thinking.
I did not open that page yet. Uh,
Yeah. Yes.
yeah,
Yes, sir. Inner side. Now we can see, sir.
yeah. So, so what they are going to do is, they, so they take the. We have to upload our CT scan images. So they will give us different 3D reconstructed images. Not only that, they have a software where the robotic surgical system will mix this image onto the surgical screen where the surgeon is operating. So he will have a picture in picture wherein while he's operating, he will have the idea of where the tumor is live during surgery. So, like when you have currently we have this picture in picture where ultrasound images and the video of the operative camera can be seen on the same screen. Like this, these images of radiology can be seen. So this is inner sight. So they integrate this. Maybe is not available right now in India, but in near future it will be available to us. So second thing, 3D modeling. So are you able to see this?
Thanks.
Okay. Yeah, this is what I was talking. So this is a robotic surgery being done. This is a tumor that is being removed, and the surgeon is seeing the image at one corner of the picture, and then he is operating. So this live guidance, like any navigation guidance, what we call C, is going to be the next in thing in robotic surgery, I think, in the near future. So I just want to share this. Maybe most of you may be aware of these softwares and technology. So with this, I end my talk. Over to you, Dr. Dileep.
Yeah. Thank you, sir. Thank you for your inputs. I have a small query for Prasad sir. Sir, as Vamsi Krishna sir has told, the invasion of the renal sinus is very important because in many cases we see the tumor will be extending exophageal into the perinephric space, abutting the pelvic axial system also. But can we say if it's just extending into the perinephric space, bulging into the perinephric, not extending? Can we say it's perinephric fat invasion or renal sinus fat invasion or calcium invasion, or should there be any other findings to suggest those? Because well
Uh,
encapsulated lesions can protrude into the spaces but may not invade them.
Correct, correct. Because the limitation of CT and MR is that we cannot make out the renal capsule separately from the renal parenchyma. So we depend the direct sign, like you said, is the frank direct extension of the tumor into the perinephric space, where we to be more specific, at least 10 size of lesion should be there beyond the renal parenchyma to say that there is extra renal extension, which is again a little bigger. 10 is quite bigger size only. But we depend more on the indirect signs like perinephric fat standing and ill-defined margins of the tumor along the perinephric space, or again ill-defined margin of the kidney along the perinephric space. When these are blurred out, then we can predict that possibly the tumor is extending, has a perinephric extension. And similarly, there can be associated perinephric facial anterior or posterior renal facial thickening also, where again we can possibly suggest that there is possibly extension into the perinephric space. But again, the limitation is the peritumoral edema and peritumoral inflammation. That again we cannot differentiate whether it is just a frank to peritumoral inflammation or the frank extension into the perinephric space, unless we see tumoral-like enhancement in the perinephric space.
Okay. So just by bulge, we can't say that it is extending into the perinephric space or renal sinus fat.
True, absolutely. I think ill-defined margins is the key, and the perinephric fat standing.
So micro invasions, obviously, we can't identify
Yeah.
based on CT. If there is frank invasion or the some irregularity of the capsule or perinephric fat standing, then maybe we can say. Yeah.
Yes.
Sir, and to Vamsi Krishna sir, the role of any lymph node resection, because sometimes in normal patients also we see para-aortic lymph nodes which might be small in size, but in the case of RCC, left para-aortic lymph nodes at the hilum, which are showing normal fatty hilum, but is it important to mention those in a case of RCC?
Definitely, sir. Uh, if there is an altered architecture of the lymph node and they're enlarged, so the threshold to do a radical. See, there are many clinical decisions. One is a radiological information we get the renal or Padua or the nephro score, the clinical background, young patient, elderly patient, his baseline renal function, involvement of the other kidney, multiple tumors. So the decision has multiple inputs, the factors. So the factors that is okay, there is some lymphadenopathy. So maybe a partial, the decision to shift towards a radical nephrectomy will be more if you mention there is an abnormal lymphadenopathy, not a normal hilar normal architecture lymph node. And we don't do a lymphadenectomy for a partial nephrectomy. So it defeats the purpose. The partial nephrectomy is done for an early incidentally found tumors. So the idea is they can be cured very easily with radical, and obviously with partial, the success of the procedure should be 95%. The 5% recurrence is same with both partial and radical. So when this is achieved, then we do a partial. So if there is a lymphadenopathy, the 5-year survival, everything turns down and the survival will be only like 20 to 25%. If there is a doubt of lymphadenopathy, all those things, the case will be for radical only, not for partial. So if you can mention, definitely the lymphadenopathy is there. They are more than 1.5 centimeter in size, and the hilar architecture of the lymph node is altered, then that surgeon definitely will shift his threshold towards more of radical than partial. It will definitely add to the information.
Because the RCCs, we generally think that they're hematogenous spread and bone metastasis we look for, but generally we might miss those lymph nodal enlargements sometimes. So
Yes.
that is important. Yes. Thank you. I will see if there is any other questions. I think no more questions. Yeah, I think we'll wind up. I thank the Vijaya management and LT Kishore sir for giving this opportunity to organize this wonderful webinar. And I thank M.Ch. Krishna sir and Prasad sir for graciously accepting and speaking on these topics, and the technical team for making it happen. Thank you.
Thank you, sir. Thank you, Mr.
Thank you, sir. Thank you all again.